1 in 200,000 getting serious liver injury. And at the same age group, women in their 40s, in the UK, 15 in 1,000. So 30 in 200,000. 30 times more women die from breast cancer than need a liver transplant because of UPA.
Frankly, statins, which are widely prescribed at fairly high doses, come with a warning that this can cause liver failure. And traditional birth control pills come with a warning that this can cause blood clots. And I think in both of those cases, the rate at which those complications happened is higher than the rate you're talking about. So why is UPA being held to such a different standard?
It's actually progesterone that does most of the driving of the normal breast to proliferate, so for the cells to divide. And so every time you go through a menstrual cycle and have a period, so that breast tenderness that you feel before coming on the period, that's the cells dividing, swelling up the breast, and that's driven by progesterone. It really shows the dramatic effects of the anti-progestin Ulipristal acetate on the normal breast. So not only does it reduce the number of cells that are dividing, really quite, as I just said, dramatically, but it really changes the structure in the breast. And it reduces the stiffness of the breast, the organization of the collagen, and those are things that lead to cells becoming cancerous.
Welcome back to Kicking Cancer's Ass. I'm here at the 2026 Rise Up for Breast Cancer Prevention and Women's Health Conference, and I am thrilled to have Dr. Sasha Howell from the other side of the pond. And he is a medical oncologist from Manchester, England. And our conversation today is going to be about prevention of breast cancer. So, with no further ado, I'm going to ask Sasha, tell us a little bit about how he came to be focused on prevention of breast cancer.
A really very good question, and the honest answer is that I followed my father into the family business. So, I was a medical oncologist, but my dad was also a medical oncologist, and he had actually set up a family history clinic in Manchester. And it was a passion of his that became a passion of mine. And so I just followed along and carried on doing the same kind of work that he'd been doing for decades.
So I have to ask, did you actually practice with your father?
6 years.
Okay.
For the last 6 years, before he retired 2 years ago, we did work together in the family history clinic, which is why we call it the family history clinic.
Before we get started, I want to thank Paxman for making this episode possible. When I was going through chemo at UCSF in 2023, I used Paxman's scalp cooling system, and it worked. I kept my hair when I thought I was sure I'd lose it. That mattered more than I expected it would. It's the same technology that's helped tens of thousands of cancer patients worldwide over the past 25 years. Because of Paxman's sponsorship, we can share the research and insights from the UCSF 2026 Rise Up Conference with you. So if you're facing chemo and want to explore scalp cooling, visit coldcap.com. Link will be in the show notes. Let's get back to the episode. All right. So I know your passion and you're here speaking about preventing breast cancer. And, in my family, the only way to prevent breast cancer was to surgically remove your breasts. And even that, as we were just talking about, is a 95%, which means not complete. So kind of sounds like a pipe dream. So would you share with me, what does it mean preventing breast cancer? What's possible? And are we talking sometime in the next 100 years, sometime in the next 5, somewhere between that?
It's already happening. So there are already drugs out there, tamoxifen, anastrozole, raloxifene, that we know prevent breast cancers. And hundreds, thousands of women who have been taking those medications will have had a cancer prevented. So that's the things I think are a little bit difficult to get, because if you're somebody who doesn't have cancer and you take a drug and you don't get cancer, you don't know whether you were ever going to get one in the first place. And so that's the really difficult part. Of course, if you're somebody who did take the drug and you do get a cancer, then you know it didn't work. And so you are going to get that kind of, it's a bit of an unfair comparison. And we have this issue with people talking about risk reduction, which is true. It is a risk reduction, but within that risk reduction, there must be some women who were going to get one who now don't.
So, in the realm of risk reduction, how do you figure out before there's been a cancer that someone has a higher risk where, like tamoxifen for my family's particular genetic profile is irrelevant, right? Actually, all three of those drugs are not relevant for triple negative, I think. Well, maybe they are. I can't tell from, no, they're not. So how do you know which women should be taking a preventative drug because they have a risk for a certain type of breast cancer?
So you were quite right with what you said, that when you're young with a BRCA1 mutation, you are much more likely to get a triple negative breast cancer. But over the age of about 55, then it's about 50-50 between getting an ER positive, an estrogen receptor positive, versus a triple negative breast cancer. So there is still some mileage in giving the anti-estrogens to women with a BRCA1 mutation post-menopause. But that's not the meat and drink of what we're really doing, of course, in the prevention clinics. And we tend to be working in a family history clinic, which tells you what the major risk factor is. And this is currently in the UK what we do. So it's only women who have a strong family history that come through for a clinic review, and then we offer them risk-reducing medication. But things are really changing. And they're changing. At this conference, we've seen a presentation of the Wisdom trial. In Europe, we've got MyPEBs. We've already done a study in Manchester called PROCAS, and I've literally just finished a study in young women aged 30 to 39, looking at risk prediction using a comprehensive approach, and that's doing a questionnaire for established risk factors, doing density of the breast, and we used a low-dose mammogram for that, but probably most importantly is looking at the genes, not for mutations in BRCA1, BRCA2, although we did do that and excluded them, but it's looking at polygenic risk scores.
So I've heard this word a number of times here at the conference, but also previously because I advocate for everyone who can enroll in the Wisdom trial in the United States, which means if you are 30 and you haven't had breast cancer and you have breasts, you can enroll in the Wisdom trial. So go to thewisdomstudy.org and enroll. I'm saying it again. But Sasha, can you explain what's a polygenic, what is that?
So when we're thinking about mutations in a gene like BRCA1, BRCA1 has got a strong function repairing the DNA in cells. When there's a mutation in that gene, the protein for BRCA1 is not produced, and therefore it doesn't work. And that's why women get those mutations and are more likely to develop breast cancers. Polygenic risk score is made up of subtle changes in the DNA, often not even in main functional genes, and we don't quite understand why some of the changes do predispose to breast cancer, but they do. So they're single base pair changes in the DNA that are associated with a very small increase in the risk of breast cancer or a very small decrease in the risk. And so individually, they don't have much impact at all. But we're now looking for more than 300 of those changes. And so if you're somebody who's identified, you're somebody who's inherited many more of the ones that slightly increase the risk individually, together, they can really markedly increase your risk of breast cancer.
Now, going back to Wisdom, because one of the things that I believe they released, or at least Dr. Esserman has spoken about, is some 70% of women who did show with some polygenic risk had no family history, no indication. And so what they're advocating is, shouldn't we do this genetic testing on the whole population so that if someone is a candidate for intervention that prevents breast cancer, we can find them? So I don't know what the thoughts are about that on the other side of the pond. I'd love to know your thoughts about it.
So my thoughts are, I completely agree with you. I completely agree with Laura that this is something that is going to happen, and I think the sooner that it happens, the better. The study that we did, we looked at polygenic risk in women without a family history, because we already know that 2/3 of women who develop breast cancer, even developing it at a young age in their 30s, don't have a family history. And we already have a service in the family history clinic for the women that do. So we purposefully targeted those women without a family history for our study, and we demonstrated with the polygenic risk score that 15% of them were above this risk threshold, which is we in there. You'll also seen within in the conference that there are different thresholds that people like to use, and nobody yet can agree on what is the perfect threshold. But we use a 3% 10-year risk of breast cancer at age 40. And so anybody that we were identifying in their 30s who was going to hit that, we started screening when their actual risk hit 3% over the next 10 years, at whatever age that was during their 30s or right at 40.
Given that we're not yet at a place where everybody's saying, let's do full population polygenomic screening, even though economically we should, because preventing breast cancer, besides we're going to save lives, that's priceless. Besides, we're going to have some expense for the intervention medications. Cancer is so expensive that reducing it or early stage detection is just economically sound policy. But right now, what would you tell women to do? Like, can they advocate for this? Can they ask for it? What kind of doctors do they go to and say, I want to spit in a tube and have a polygenomic assay done on me?
I have to admit, I don't know what the situation is in America.
Tell us in the UK.
In the UK, there is a what we call CE marked, so it's approved by the European Agency for Breast Cancer Risk Prediction. So women can go out and spend £500, about $650 on this assay. The difficulty they've got is that then someone has to interpret that for them and be prepared to provide them with risk-reducing medication. And most areas of the UK don't have anything like that service set up. We do in Manchester, but we are one of the few people that would do that. But then it's incumbent upon us to do the studies that influence policy. That's what Wisdom's doing. That's what MyPubs is doing. And we're about to, having successfully completed our first 2 studies, we're now trying to launch a much larger, very large study in the north of England to do the same thing, which is to influence the National Screening Committee so that we can get risk stratified screening. And when we've got that, we know the risk, we can then offer the risk reducing approaches as well.
Okay, which brings me to one of the more interesting things that has been discussed at this conference. And I know the initials are UPA. I don't know the science of it, but I think it's in the anti-progestins world. So could you explain what an anti-progestin is, why people are excited about UPA, and how that fits in the risk-reducing menu that, even though it's not available everywhere, that we're hoping becomes more widely prevalent?
So progesterone, as I'm sure you and most of your listeners will know, is one of the main female hormones. What a lot of your listeners and watchers won't know is it's actually progesterone that does most of the driving of the normal breast to proliferate, so for the cells to divide. And so every time you go through a menstrual cycle and have a period, so that breast tenderness that you feel before coming on the period, that's the cells dividing, swelling up the breast, and that's driven by progesterone. And we know from preclinical studies, so studies in rodents, and we know from a lot of epidemiological evidence, the progesterone reduction can reduce the risk of breast cancer or mammary cancer in mouse studies. And what we and others are doing is trying to test anti-progestins, so blockers of the progesterone receptor, to see whether or not that will reduce the risk of breast cancer. Ulipristal acetate is such a selective progesterone receptor modulator, and we put that into a study of 24 premenopausal women recently, and those are the data that I was presenting at the conference.
Are you able, I know if it hasn't been peer-reviewed or whatever, I don't want you to have to share something that you're not ready to share, but can you share kind of high-level trends, things you're seeing?
So it has been peer reviewed.
Great.
And it was published in Nature in December, so very recently. And it really shows the dramatic effects of the anti-progestin ulipristal acetate on the normal breast. So not only does it reduce the number of cells that are dividing, really quite, as I just said, dramatically, but it really changes the structure in the breast. And it reduces the stiffness of the breast, the organization of the collagen, and those are things that lead to cells becoming cancerous. So we think we're reversing that process, and we can see that in the MRI scans that we did. We reduced the fibroglandular volume there as well, which is a surrogate for breast density that we usually measure on a mammogram. So very, very encouraging signs after only 3 months of treatment. And now, and what we've had a lot of conversations with at this conference is, what's the next study? How are we going to take this forward so that we can get to a point where we're doing a study that has breast cancer incidence, so the number of women that develop breast cancer, as the primary endpoint?
Now, my understanding is UPA is already an FDA-approved drug in the United States. I'm sure it's also approved in the United Kingdom. Progesterone got a really bad name from the Women's Health Initiative, right? And I know it was a synthetic, and I don't know what UPA, if UPA is bioidentical, but how is this tolerated? What are the risks to women about an anti-progestin?
So there are large studies that have been done looking at ulipristal acetate in women with uterine fibroids, so benign tumors well, we say benign tumors, but a lot of the advocates who have been here at the conference have said, don't use that word because fibroids can wreck a young woman's life. And ulipristal acetate works really well to shrink those fibroids, to stop the bleeding. And quite often, what was happening was that it's because it's given in 3-month courses. It'd go up to about 8 courses, and a lot of women would then just not need surgery. So it would actually prevent reverse that need for hysterectomy and help to maintain fertility. So really great treatment. It did have some side effects. It can cause things like some breast pain. It can cause a little bit of nausea. It can cause a little bit of anxiety in some women as well. The concern was that it was identified, and this was when about just under 1 million women had taken Ulipristal for fibroids. It was identified that 5 women had had liver failure. And those women needed a liver transplant, which of course is a very serious thing. But that is 1 in 200,000 women. Now, there are some women who get less serious liver issues, but they recover from those. So the 1 in 200,000 was deemed a high enough number for the drug to be paused, so suspended completely for a while, and then only reintroduced over in Europe, really for 1 course, 1 3-month course, which is what we used in our study. But that's never going to prevent breast cancer. We need a longer duration or pulses of treatment over years, is what I would hypothesize we need to prevent breast cancer. But one of the things that I was presenting at the conference is 1 in 200,000 getting serious liver injury. And at the same age group, women in their 40s in the UK, an unselected population, 15 in 1,000. So 30 in 200,000. 30 times more women die from breast cancer than need a liver transplant because of UPA. And if we do that risk prediction that I was talking about, then the risk-benefit ratio just starts to go up and up and up. Put it the other way around, it's the benefit-risk ratio that goes up. You start to see way more benefit than risk when you're dealing with women who are at increased risk of breast cancer. So we need, again, all in agreement in this conference that we should be pushing again and pushing to the regulators and saying, look, when we're identifying women at high risk, particularly of aggressive breast cancers, then we should be using this drug in another clinical study and really carefully evaluating its efficacy, how good it is at reducing breast cancer, but also its safety.
You hypothesize that it will be a series of pulses and you can get a long-term breast cancer reduction, or do you think it's going to be a form of hormonal contraception that women with high risk have to take? And just to add two questions to the thing, I know because of my health, I have doctors who monitor my my liver function to ensure nothing I'm taking is causing liver damage. In the risk of 1 in 200,000, could we add regular hepatic function monitoring so that you don't go from nothing to liver failure? There's signs, I'm guessing. So I'd love if you could address both of those questions.
So the first question about contraception is right on the button. So we didn't actually do the first study of ulipristal acetate. We were doing it at about the same time, but Carolyn Westhoff, Malcolm Pike, and the team in New York got there first and published, again, showing reduction in proliferation. But Carolyn is a gynecologist, and so, OBGYN. And so she was also really keen to try and develop ulipristal as a contraceptive. And so it was very, very carefully monitoring for ovulation whilst the women in her study were taking ulipristal. Unfortunately, because of the liver issue, the additional studies that Carolyn was doing were stopped. It is still possible that it could be a contraceptive, and that's the Holy Grail, where you've got something that you are using for a lifestyle contraceptive, but it's also reducing your risk of breast cancer if you're at increased risk. So that's not gone away completely, but unfortunately, because of this liver issue and what we're going to have to do to try and sort of push back, it's something that it's, I wouldn't say shelved. It's still very interested, but it's not, as far as I'm aware, it's not being really pushed hard. The other issue is about liver function monitoring, and the problem that the European Medicine Agency had with the 5th case of liver failure was that woman was having liver function tests monitored, and that they couldn't prevent the liver actually failing. However, I know from our very small study that we had, because once we'd come back on board after a suspension because of the liver issue, we had to do every 4 weeks, we do liver function tests, and we saw 3 women where they were slightly raised, but they went back down to normal again at the end of the course. So of course you can monitor for the majority, but women who are then choosing whether or not they want to go on this drug will definitely have to be told, quite rightly, that there is a very small chance, 1 in 200,000, that you might get severe liver failure.
Frankly, statins, which are widely prescribed at fairly high doses, come with a warning that this can cause liver failure. And traditional birth control pills come with a warning that this can cause blood clots. And I think in both of those cases, the rate at which those complications happened is higher than the rate you're talking about. So why is UPA, or Ulipristal, why is it being held to such a different standard?
We don't know. We all agree that it doesn't really make sense. None of us sat on any of the boards that were assessing the data in the regulatory agencies. There was, it would appear, even some disagreement between the different committees in the European agency, because the publication of their assessment said, Committee A says this, and Committee B says the other. Committee A wanted complete ban, stop this drug ever being used again. Committee B said, well, no, women who can't go for surgery, what you're suggesting is not fair. And so it was reinstituted for that group. So there's already a little bit of, suspicion is a strong word, but a lack of understanding about why that decision was made. And there are also some issues about the ages of the women that were involved with, or that had liver failure, and several of the women were over 50, and we think, well, that's not the age group that we would want to use the drug in, and not the age group that the majority of women who've ever used the drug were. So I think there are a number of unanswered questions there, and certainly something that we want to take forward.
Yeah, it's interesting that you talk about the age. When I was saying to you that I had the prophylactic salpingo oophorectomy, so no ovaries, no fallopian tubes when I was 38. And the surgeon said, and we're going to put you on HRT. And I said, oh, about this study. Like, isn't HRT going to increase my cardio risk? And he looked at me and said, all right, first off, no. Second, the study, the women that had that elevated risk in the Women's Health Initiative. So people who look it up and have heard, like, what about HRT? They were way older than you. They were not looking at 38-year-olds. You would have these hormones in your body, except that we did this prophylactic surgery. And your body, your heart, your bones, you need them. So this is actually good for you. It was my radiologist who was not wild about the estrogens, so we tinkered with it over time, and it tapers off. And now we're looking at women who have had cancer, who haven't had cancer, being able to take advantage of HRT because of better research. But your point that making a blanket statement, a 30-year-old woman shouldn't have UPA because a 55-year-old woman very rarely had liver failure. It almost feels illogical. Like, okay, don't give it to 55-year-olds, right? Like, or watch the 55-year-old more. But when you said we wouldn't intend it for that age, like, again, in your magic world, the world that you would like to see provide the science plays out, we know, like, we still have research to do. What age would you be thinking about using UPA? And again, if it can't be a contraceptive, or if we can't reach that holy grail, like, who could this help?
So I would like, this is, of course, assumes that the next studies are successful and we demonstrate safety. And in that situation, I think it is the earlier the better. And the reason to say that is that there are some very nice studies that have come out over the last couple of years that show that the genetic changes, the earliest stages of cancer development in the breast come in late adolescence. So the first chromosome translocations, first genetic abnormalities are very late adolescence. And then just bit by bit through the 20s and 30s, more mutations and more genetic abnormalities occur. And that's why we start to see the cancers developing in the 30s and 40s. And we get this growth or rise in the incidence, the number of women developing breast cancer in the 30s and 40s, which is way earlier than the other cancers like colon or lung, the other really big killers. So it's due to the drive of the cells by these female hormones primarily. There are lots of other factors as well, but it is primarily the drive of estrogen and progesterone. And so really the sooner we start, the better. And women should have a choice about when they want to start. I would suggest after they've had their family. They think, right, that's it. I've had my 2-3 children by the time I'm 30, 35, and my breast cancer risk is high. I don't want breast surgery. Then, well, let's try some Ulipristal acetate. And if I tolerate that well and I can stay on it for a period of 15 to 20 years, that will effectively reduce over that period. Now, I'm not saying be on it continuously during that time, but pulses of treatment during that time will significantly reduce the affected number of menstrual cycles, and that will reduce the breast cancer risk.
It's just really interesting. And the idea of there's a period of time for a lot of women, late adolescent in their 20s, where they also do not want to have children. And if you did the pulses then, and then they decide they're going to have children in their late 20s, early 30s, what have you, and then go back, is that something people are looking at? Or is that kind of, no, we don't want to do that?
I think you're getting out your crystal ball.
Well, I'm not a scientist, so I'm glad.
And looking a long way into the future. The way that we have to do clinical trials is carefully design one study and one population. And I wouldn't be looking at a sort of 20 to 25-year-old age group. I don't know how things sort of went with your family in terms of um, BRCA1, but we certainly in the UK try to um, support very young women not to have surgery in their sort of late teens and early 20s, because the chances of them developing a breast cancer in that time is so low. You could argue we're not talking about surgery, we're talking about giving a drug to try and reduce the rate of mutation and therefore the chance of developing breast cancer later. But I still think that this very early age, before perhaps, maturity has been reached for decision making. I feel a little bit nervous saying that because, of course, some people really mature very, very early. Some 20-year-old woman will be a lot more mature than I am now. But I think I think we really have to be thoughtful about that. For our study, the youngest age that we were happy to recruit was 25.
25.
Yeah.
Okay.
But we actually didn't get any women under the age of 30.
Yeah. I mean, the challenge with the younger population is the probability that they'll ever get breast cancer is low. The probability that they'll get it young is really low. And so you have to do massive studies that are not economically feasible. So it'll be interesting to see if people in the United States, doctors can prescribe off-label. And if they start to see things working, does UPA have any kind of sustained fertility issue? Like I thought it's what's used in like emergency contraception. So does it have, it's one of the things used, it's not the only one. But does it have fertility concerns? No. So, all right, I'm going to wrap this up with my favorite last question, which is I ask everybody if well, please give advice to anyone listening about how they could kick cancer's ass.
Support clinical research. Absolutely. Find your local centre, find out whether there are any studies ongoing. We're just putting all of we're redesigning our website in Manchester with all of the clinical trials across the whole of the greater Manchester area to try and make that process easier. And I'm sure in the US, wherever you are, you'll be able to find out what clinical trials are available. We cannot make any progress unless people are involved in clinical trials from all races, from all social determinants. So we really need as many people as possible to come forward for clinical trials so we can make this and make these differences.
And for people who are worried about clinical trials and am I being experimented on, what's the answer?
These are experiments, but you're part of a wonderful thing, which is trying to drive science forwards. Now, of course, it's your absolute right to say that you don't want to do that. But then I think if we had a whole bunch of people around this table, we could have a really good conversation about why research is such a good thing and that we can't actually make any advances without it. And so, a lot of the advocates that are in the room in this conference will, of course, absolutely sing the praise of research because they know, having had breast cancer, that they wouldn't have been cured or they wouldn't have treatment for their advanced breast cancer had it not been for those clinical trials. And I think that's a key understanding. And of course, what we're now talking about is trying to do the research that enables us to prevent it in the first place. So it's that's obviously what I'm passionate about. That's my, I'm going to say 9 to 5, but it's a lot more than that. Yes. But it's that's what we really need. So involvement is what I'd like to see.
And the part I want to add is I think it's a myth that these are dangerous. So many safety parameters are in these trials. So yes, you're advancing science, but you're usually getting better than standard of care and you're being observed closer than you would normally be. And so I always considered it a gift that I was BRCA1, and people think that's crazy. But I said, look, breast cancer doesn't scare me. Late stage breast cancer scares me. And you look at the survival rates, and early stage breast cancer is way in the upper 90s, and late stage breast cancer is down in the low 30, like below 30. I would choose the odds. So I'm not scared because I was watched so closely. But it's the same thing if you're part of a clinical trial. You're being watched more closely. I would argue if you want to get better medical care, not just for the future, but right now, be involved in a clinical trial because you've got great scientists and doctors, and they are intensely curious about watching you.
Completely agree, obviously, with what you've just said. And of course, if you don't like the explanation that you've had about the clinical trial, or even if you start the clinical trial and you feel like something has gone wrong, or you no longer want to give your consent, you can withdraw it, and you won't lose out. Your standard of care will be the same. So I think it's really important that we do get that message across. And you're absolutely right that generally the research active centers have better outcomes than those that aren't.
So I want to thank you. Thank you for the work you do, for what you've given your life to, for the not 9 to 5, but probably 24/7 that you think about, dream about, lobby about, study. I know I'm a beneficiary. I think everyone listening is a beneficiary. And so, Dr. Sasha Howell, it has been my honor to have you on Kicking Cancer's Ass.
You're grateful. Thank you.